So week 9 is a pretty intense week. It's all about the musculoskeletal and neuromuscular issues, and they're not all not just black and white. Neuromuscular are really more related to children. So I'm going to try to give you that information that you do need to understand. Okay.
Sure.
So
Sorry,
yes,
quick question. Sorry to interrupt.
no problem.
Is anybody having problems opening the
The word.
handout?
Can you open it right now in the, oh, you know something? It
It
went,
doesn't let me.
it,
It says unauthorized access denied or
hold on, hold on.
You
You
have
know
it on
what I did?
announcement.
Hold on, I'm going to,
That was with the first one. I couldn't open it either.
there you are. Go look at your chat box.
okay.
I inadvertently sent it to one student. It's to everybody
Oh,
now,
okay,
okay?
okay. I see it
So
now.
now you
Thank
have it,
yeah,
download it, take it.
thank you.
I always, because I know sometimes those attachments don't work, I always put it in the announcement for that week when I do the recording. So, but anyway, there you are, you have it. So please get it done. All right. So let's go ahead and get started with our PowerPoint tonight. And the PowerPoint has a lot of information on it, like always. These beginning pictures are actually pretty something that you should pay attention to. I mean, yes, crutches and casts, children, children get pretty casts. You go to Nicholas, you're going to get a colored cast. You go to the Baptist pediatric side, you'll get a white one. And that's the difference. And Nicholas does have your pediatric orthopedic techs. So you have somebody really taught well how to deal with children, fractures, etc. Okay. Now that baby up there, that's called a Pavlik harness, and that's for hip dysplasia. And it's actually not accurate the way that they're displaying it. There should be a t-shirt, a onesie, something underneath, because that baby's going to take those legs and move it, and it's going to scratch and create blisters and redness. So there should be a t-shirt underneath there. And we abduct those hips there. And the bottom one is a skin traction. Excuse me, I'm just going to hang up on this person. No clue. Spams. We have a house phone. That's spam, spam, spam all the time. And the bottom, as I said, is skin traction, and it's called buck traction. And what you need to see about that picture is the foot's not at the end of the bed. There are cords, and it goes to a hanging weight, and it's freely hanging there. And it pulls the leg. Usually that is used for fractured hips in old people, right? But it is used for fractured femurs in children because it pulls the bones together, stops those muscle spasms and those bones from sticking in the muscles, and it's a lot of pain. So sometimes we have some children that are going to be immobile, for many reasons. It could be congenital. There are progressive muscle weaknesses, or they have brittle bone disease, which is the degenerative, infections, injuries, crush injuries, and sometimes therapy will keep them in bed for whatever the reason is. Like Guillain-Barré, you're on bed rest, you're not up and moving. So many of those things will cause the child not to be able to move around. Remember, when you're not moving, a lot of things happen. Your muscles, they don't work, they get atrophied. We need to do something, physical therapy, range of motions. We need to be aware, nutrition-wise, the skeletal, the bones, the demineralization, making sure they have good calcium in their diet. And of course, you're talking about the heart, the lungs, you're talking about pulmonary embolus, deep vein thrombosis, you're talking about atelectasis. All of those things happen in adults, they also happen in children. Now, children tend to not deal with isolation really well. They just start to regress, they get angry, they get mad, they feel helpless. Our job as nurses, if you work in the pediatric area, How do you keep that child entertained? How do you distract them? I mean, the hospital offers a lot of different things, but it's not all the time. So if you work night shift, I used to sit down and play games with my kids. Mario Kart, I actually got pretty good at that, working night shift. Well, of course, when my work was done, and tried to entertain an older child, especially in the cardiac ICU. They've had surgery, they're almost going to the floor side, and we'll just stay up and play games. And they just feel pretty normal when you do those things. Remember a kid who's in the hospital a long time. It's not just the kid that's having these issues. There's a family. You got parents who are trying to work, trying to see the child, take care of the other children, and it's really hard. And then don't forget that kid at home, you know, the brother or the sister. They're going to worry even if they FaceTime today, right? I mean, COVID was horrible. Families couldn't go in, mothers, fathers, they rarely let them in. And then you have, of course, you know, the brothers and the sisters. I mean, of course, then you have abuela. I mean, abuela has to be there all the time, and we know that. So there is a built-in thing in a lot of these pediatric hospitals. I know Nicholas has it. Every floor has a family group. And these family groups usually meet once a month and they talk about what's going on. It could be that long-term cardiac child, that long-term respiratory child, that long-term neuro child. Could be CP, could be brain tumor, could be whatever. But they talk, the parents, and they share what they're going through. And that does really help these families to get through this. Now we're going to go on into musculoskeletal things that can happen. We know that there's muscles, ligaments, and tendons, and you can twist them, you can bend them, you can fall, bruise them, and you know, this could be during play or, of course, sports. Kids are so competitive. Now, contusions are an ecchymotic area, black and blue, right? And you think it's not really a big deal. Remember, it could be underneath squeezing vessels and decreasing blood flow. So even with an ecchymotic area, and that's actually pretty big, I would be checking the neurovascular signs distally, making sure there is blood going through, especially if that was a crush injury. Now, dislocations is when the bone comes out of the socket. You know, kids have that nursemaid elbow. You like to swing them around, those 2 to 3 year olds, and all of a sudden their elbow clicks and it's out of joint and it hangs by their side and they can't bend it up. They need to go to the physician, urgent care ER, and they go click and it's back into shape, no x-rays, and they go home and they usually just put like a sling on them just to relax that elbow. Their tendons are so malleable that they'll just pop out. That's one way. Another way is Down syndrome. You know, these children are so hypotonic, they can take both feet, put them behind their head, but encouraging that could pop the hip joints out of the socket. And that could create a, an interruption in blood supply. And then it could create some sort of necrosis because of no blood supply. So we wouldn't do that. You know, I was telling a class yesterday, the hardest dislocation I've ever been involved with, I mean, I've seen shoulders, pop them back, not a problem, but an ankle. This ankle was so tight. I mean, we had to sedate this, was a teenager, so much to try to pop it into place. And when it popped, I just couldn't watch it. And I was being there with the physicians. Now, sprains and strains are commonplace, right? I mean, I was in high school, college, I was an athlete. And I would, for instance, going and playing volleyball, get up, spike the ball, come down right on my ankle, and you could hear it go, you know, the tendons, you know, they were ripping. I think sometimes these sprains are harder to heal than a fracture. Today, though, they really are immobilizing them, sometimes even with casting. When I was that age, you know, they didn't do it. We know with sprains, immediately it's going to swell. I mean, I got to learn after, I don't know how many sprains, you get a sprain, stop, don't move, put your foot up in the air, You know your coach is bringing you ice, and get it wrapped up, and you can decrease that swelling just that little bit, and it can help with the healing of it. Strain is usually when you do something over and over and over and over and over again. Bicycle riding, shin splints, those things could be those strains. Now, what do you do? Now, I told you I sat down, put my foot up, got ice on it, got an ace on it. That's all rice. Rest, ice, compression, elevate. And then you're going to eventually do that immobilization. They've got splints they use. They've got, today, as I said, even cast on some really bad sprains. They felt that the recovery is better. Now, fractures, commonplace in children, but not infants. If you see an infant that has a fracture, it should be looked at closer. You know, as I said, I had this 3-month-old who's had a fractured skull, and it wasn't just normal. I mean, usually these infants, their bones are softer. They don't break easier. You know, they're very difficult to break. Takes a lot of force. And then, of course, we didn't just do an X-ray of the head. We did of the body, and we found fractured ribs, fractured femur, fractured humerus, all different stages of healing. And the kid was only 3 months old. So be there to protect your children, okay? That's one thing that a pediatric nurse should do. Most common is you fall down, you put your hands out, right? Fractured wrists, your radius and your ulna, one, both. And I've seen bilateral on those little hoverboards. I mean, both. At first Christmas they came out, I saw 3 kids with fractured bilateral radius and ulna. Now, there's all types of fractures, whether it's open, closed, it's pieces, etc. But the simple one is usually what we get. We know it, it's swollen, it's tender, mobility is low, and we'll do an X-ray and put a cast on it. Now, open ones create a little bit more of an issue. Whenever the bone is exposed to air, they say staph immediately. That's what they predict is going to be the organism that gets inside. So these must be cleaned out very well. Usually they'll take them to surgery or at least sedation, and IV antibiotics is your priority. You need to get that body so it doesn't get infected and go into an osteomyelitis. Complicated, fractured rib goes into the lung, right? It's another organ it damages. And comminuted is little pieces that stick into the nerves and the muscles, and it really, really hurts. Now, the biggest issue in children and fractured bones is if it hits a growth plate. And the growth plate, another name for it, is epiphyseal plate. And you can see it's at the end of the bone, and that's where the bone grows and how you get taller, how your arms get longer, your legs get longer. If you fracture that, whether it's slight or a lot, if you don't fix it and have it exactly equaled up, you're going to have a crooked arm or a shorter arm or a shorter leg or a crooked leg. So all of these, whenever you have a growth plate fracture, they will be going to surgery, have an open reduction, internal fixation, and get everything lined up perfectly so that we get this child a chance to have a normal arm or a normal leg. Now, the one thing about kids is look at the neonatal period. That's the first 28 days of life. 2 to 3 weeks, bones are healed. I mean, that's amazing. Usually we get those young kids up to, you know, age 7, 8, I would call earlier. And these will take about 4 weeks. I can't tell you how many kids, first day of summer vacation, go out and break an arm, break a leg, and they want to go swimming, especially here in Florida, right? And they can't. But it only takes 4 weeks. So at least they have the second half of summer vacation that they can get out. But get to my age, oh, it's going to be 3, 4 months before something heals. So as you get older, it takes longer time. So you get a child, you get them into the ER, they're complaining or limping. We know if they're limping, foot down, maybe it's just a sprain, but if they're not putting weight, we know that's a fracture. So we're going to take a history. Now, remember, fractures can be not just them falling down and hurting themselves. It could be abuse. And you always have to think that in your mind. You know, it's not the greatest way to think, but you might protect a child. And if you protect a child, one in your career, that's one that didn't get more abuse, right? So take the history from the parent who brings them in and the child separately. See if their stories match and see if the way that they said they did it matches the injury. Be very careful with that. Now, I always showed my kids their x-rays because there's x-ray screens everywhere in that ER. So usually in their rooms, they have it. So I show it up, show the children so they understand I got a broken bone here. Our goal is to reduce it, immobilize it, and make sure we keep that function going. And we don't want any crooked, shorter arms or legs, so preventing deformities. Now, when they go home, they got a cast on, the arm, the leg. Now, that picture on the right is the most, unbelievable, consequence of a tight cast. The whole arm is dead. It's turned black. The blood supply is gone, but it can happen. So how do we prevent this? Well, we're going to tell the parents the 6 Ps. If there's pain is getting worse, the color of the fingers, if it's a cast on the arm, is getting not as pink. You don't feel that pulse if you were able to before. It's getting really numb and I can't move my fingers now, or it's swelling. This is something to go back to the ER or to call your physician, and he'll say, go to the ER and have that cast check. It could be compartmental syndrome, right? So we need to let both child and parent know that. Now, as I said, kids casting can be fun. We could do all colors. I mean, even our little doll looks like an old Cabbage Patch doll, doesn't it? And they've got the cast just like she has. So distraction is not going to be that bad. I mean, I have knocked kids out for sedation and they want to be the color of the heat. They wanted red and black casts. So they wake up and they look and go, okay, good. Distraction, it's something more to think about than my arm hurts, my leg hurts, whatever it is. So we put the cast on. Now, how do we manage them at home? Well, basically, sticking things down them, maybe a cool hair dryer blowing. Sometimes that could be soothing. No powder, don't do any of those sort of things, and keep it dry. Can I tell you how many kids would get a cast on, go home, put your bathing suit on, and jump in the pool the same day? And the parents come in saying, I don't know about this kid, and he did it. And then he did it again. More than one child has done that. And what that happens is they have to go and get it removed because all sorts of disease, fungus, algae, whatever it could be growing underneath that cast and create more problems. Now, traction for a fracture could be skeletal, could be skin. And what it does, it pulls and it gets those bones aligned, okay? And it helps sometimes with pain. Sometimes it helps prevent paralysis. There's all different things for it. The Buck's traction is the skin, and I've gone through that. And as I said, that is usually that fractured femur. I've actually seen a boy come into the ER, swollen thigh, creating pain, really complaining of pain, and it was fractured femur. And in the ER, quick, put that Buck's on, and his pain was decreased immediately. I mean, down to hardly anything. So what do we do it for? Well, that bottom left picture is a skeletal cervical traction. Those are tongs in the head, and it's usually for neck fractures, cervical fractures. I've used it on a kid that had a C5, C6 angulated fracture that had paralysis of the right leg, couldn't move it, couldn't feel it, and his left leg, a little bit of sensation left. And that helped him go the night on a cooling blanket, preventing swelling, of course, steroids, to get him to the OR the next day. I visited that child 2 weeks later, and his right leg still had a little bit of numbness left, but the left leg was good. And it was all because I kept that neck immobile. I took control of it. And a year later, that kid came to see me, perfectly normal, absolutely nothing, no deficits at all. And he remembered me, came up, gave me a hug, and told me thank you. So traction can work, can give you that time you need to get to surgery. It can also help prevent that deformity. And like within that fractured femur, it can reduce that spasms of muscles because those little sharp pieces sticking in it really hurt. Now, there's types of tractions. I've already mentioned bucks. It's just the straight traction. And usually for the femur in the pediatric world, you'll see that for fractured femurs in the adult world. Now, when you look at Russell's traction, it's like bucks, but the leg is lifted up and there's extra tension right on the upper thigh. It's a physician's choice. They both work. Bryant's traction, you can use those for hips to hold those legs up. And then, of course, we have those cervicals traction. And that little girl with that thing sitting there is an external fixation device. Probably she's had some sort of surgical surgery. That cervix, usually the axis and the atlas, C1, 2, the openings aren't good, and they usually do surgery, and then they have to hold it stiff so that they can heal. So distraction of the fracture, we can use these external devices. Let's say you were born with an arm, a leg that was shorter than the other. Actually, I had a physician who was short and actually did both legs one at a time to gain himself 2 inches. At 50, well, whatever. But what this does for kids, they break the bone, they separate it, they put these pins in, and then the bone starts to heal. So they will grow an inch or 2 with it. And our biggest thing with this is pins are going into the skin, and it is cleaning the area, those pin sites, making sure that there's no infection going on. And we use these a lot. You will see them. They look horrible. Initially, they hurt a lot, but the outcome would be the kid doesn't have to wear orthopedic shoes, with 2-inch heels on one and flat on the other, right? And that helps a lot with posture, back pain, etc. Now, kids can be born without limbs. I knew a little girl born without her fibula. And because there was nothing they could do, she couldn't walk on it, there was no support. What they did is they did a below-the-knee amputation on her, and she had a prosthesis. And they did this when she was real little, so she never knew that she was different because all she knew was her prosthesis. When I met her, she met my children. It was from a friend that I had met. And this little girl took off the prosthesis and was chasing my kids all over the house, up and down the stairs with her prosthesis. Let me tell you, she was more mobile than most kids. And at that time, she was 5 years old. So that's what I remember about amputations. But just remember, there are other reasons, crush injuries, accidents, etc., that can create an amputation. Now, what do adults go through when they get amputation? Well, it's the pain, it's the phantom pain, right? All of those things are the same in children. Now, children love sports, right? They love competition. They love to win. It's hard, but some of these sports, soccer, football, can be really, really rough contact. Or it could make you, do things more than you normally would because you're going to win, right? So making sure that these children have the proper equipment, proper supervision, to make it a lot more fun. And then, of course, warming up before they go out. I mean, does kids stretch before they go outside to the backyard, start running around, riding their bike around the block? No. So they're more apt to get those injuries, and those are those overload injuries. Overuse syndromes, it directly makes me think of those gymnastics. They do these things over and over and over again. And they get stress fractures. Let's say they're doing floor exercises and they're banging on their feet. And they get these stress exercises. So it is common. Now, the first slide, that hip dysplasia, right? Well, it's called developmental dysplasia of the hip. So you've got the hip bone, and instead of that socket going in, it's up top. So just think about where that leg went. It went shorter, didn't it? So one of the symptoms you would see is one leg is shorter than the other. That's usually the first clue to it. And it's more girls than boys. What you see is that you can't, abduct it very well, doesn't move as well. You turn them over, their butt cheeks or the gluteal folds, one is higher than the other. There's a positive Ortolani, positive Barlow. I mean, why do you think pediatricians, when you take your infant in for the first visit, take the knees up and pull them out and do this? They're waiting for the click. They're looking for it. They're measuring the legs. They're turning and they're looking at the butt cheeks. They're checking for this hip dysplasia. So how do we treat it? Well, remember I said it's 2 to 3 weeks on infants, neonates, that they'll heal quickly? Well, we get that Pavlik harness on, and that picture is a correct picture. You see there's something underneath preventing that rubbing, and it needs to be on again 23 hours a day. We take it off to give them a bath, to clean them up and put it back on again. If we don't have the ability to get the hip back in socket, they might put a spica cast on for the first 2 years, off and on. And then older kids, if we haven't done anything, those tendons, muscles, they're so tight, they've got to cut them, open them up, stretch them to get that hip back in. So we don't like to wait that long. But the goal of a Pavlik harness is to abduct. We had adduct and abduct. You need to know this. It's an abduction. Now, club foot is when the feet go in, out, up, down. They're just not the way they should be sitting, okay? There's 4 types. You do not need to know the names, just to know that the feet are deformed with the ankle. Of course, we need to do this quick because remember, these bones, 2 to 3 weeks, we can correct them. And what we do is what we call serial casting. And I love this picture, which shows you that's every week it is changed. Every week. That's how quickly they heal, okay? So they put them in cast, and every week they change them. They get their feet where they need to be. And as they grow older, they need to be checked, up till adolescence, making sure their feet are in the position the way they should. They might need physical therapy or some correction, but they really need that follow-up. Now, osteogenesis imperfecta, very rare disease. I've seen actually 2 in my career, and I was afraid to touch them or change them. I would use a blanket and have another nurse on the other side, and we both pick them up to change sheets underneath and clean them up, etc. Because just touching them, moving them can make bones break. That's how sensitive they are. What do we do for these children? Well, no cure. And we just do more supportive type stuff. They might give some IV biphosphonate therapy, to try to help decrease it. Good nutrition, calcium, vitamin D, all the things. But our goal is, we know that these kids, many break so much all the time, they're going to end up in a wheelchair. These are the children that you'll see at Nicholas in their motorized little wheelchairs, go into the cafeteria, and you'll hear them going, beep, 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 trying to get there. And you know by looking at them that this is what they have wrong. Their brains work, okay? That's my point. Their brains work, but their bodies are broken, okay? Leg calf birth disease is an aseptic, see, no infection, necrosis of the femoral head. So you've got this femoral head going right into the hip joint, and somehow blood supply stops and it becomes no blood supply there, and it starts to degrade that hip joint. So it hurts and it's painful. Common in white males ages 4 to 8. They sometimes will end up with osteoarthritis as they grow older because of this. But usually what we'll see is the kid will start limping, stiffness, their range of motion's decreased, and they don't remember falling down or any trauma that's going on. And when they sit or go to bed, wake up in the morning, it's going to be worse because it's stiffened by then. So they do tests, they find it, and what do we do to treat it? Well, we want to keep the head of that femur. We don't want to have to do a hip replacement on a young child. I mean, that's pretty, drastic. So we might put them on that buck's traction to hold that leg straight, to prevent the moving of it so that it can heal. We will have them on rest, no weight bearing, and then steroids, non-steroidal ibuprofen. One of those will be given. Rarely we'll do surgery, but the thing is that home traction. And then whenever you're dealing with bones nutrition, give them high protein, right? Not too many carbs because you don't want them gaining weight in that bed because they won't be up and moving around like normal. Now, there's 3 curvatures of the spine. Kyphosis is the humpback. You think of the old lady, old man just bent over, that's kyphosis. Lordosis is not seen as much, but it's the lower back curves in and you almost sway back. It's what it's called. You sway backwards because you don't lean forward with it. A lot of children that are overweight, you might see this in. Now, scoliosis is the one that Essie loves, NCLEX loves. They love to talk about scoliosis. And it's S-shaped scoliosis. S for scoliosis, S-shaped curvature. And the problem is if that curvature is too big, it pushes into one of the lungs. So the lung can't open as much. Usually it's respiratory issues that make this child have to do surgery. This usually happens right at that adolescent growth spurt. And they're growing so quick, and then you see that curve come right onto them, okay? Now, how do we treat this? Well, remember, you got an adolescent body image, big deal, right? They really don't want to be seen in a brace, but it is 23 hours a day with a brace on. They take it off the shower, put another shirt underneath and put it back on. They even have it in bed, and then really extensive exercise, physical therapy. Now, if it's greater than 40, 45 degrees, usually when you see questions regarding this, they're saying 50 or more, you need surgery. And that surgery today, they've changed it a little bit, but for purposes, because this is where, we are with testing, etc., they put in Harrington rods. They're actually doing fusions now in real life, but we have done these it's a rod and it attaches to the spine all the way down, and you are made as straight as possible. Now, it's not perfectly straight, but it's the best it can be. Now, post-operatively, these children, this is little things have been attached. They take time to adhere to the spine, so we must log roll. these children, right? Because many times they have them on their tummy, and then they have to, well, how are you going to go to the bathroom, right? You have to turn over, and they're on bed rest for a while till they can get them up. Now, osteomyelitis is an infection of the bone that can happen. Usually you start seeing a fever and the chills. And if we did a CBC, we're going to see the white count really up. Leukocytosis. Leukocytes, osis means a lot of them. So elevated white count. We always do cultures from the area. If we see an area where it's been punctured, it might be just a toe, it might be just a finger, or it could be a whole leg, a whole arm. It could be anything. And we'll do those biopsies or aspirates to find out what was the organism, what's the bacteria in there, so that we put them on the correct antibiotic. So what do we do for osteo? Well, as I said, a lot of times it's staph getting in there. So they are on long-term antibiotics. Usually they go home with a PICC line and they're given antibiotics. And it's usually an aminoglycoside, which is vancomycin. And if you remember pharmacology, vancomycin, you have to do peak and trough levels because it can kill your hearing, okay, affect it. Also, it can damage your kidneys. So we really need them compliant in getting these lab tests and getting it done. And always you monitor renal and your hepatic because of absorption, excretion. That's always done, but especially renal because it can cause damage. Now with osteo, we have to mobilize whatever it is, a limb, a finger, toe, whatever. And most of them are on rest, bed rest, keep it immobile. And diet again. Remember, diet's always important in kids and with healing. So these children, high in protein. Again, we don't want them gaining weight. It's not so much carbohydrates, not so much fat. But vitamin D, calcium, making sure they're getting proper nutrition. And again, they are, again, secluded. They're by themselves. Distract them somehow. Give them something to do. Now, we've gone over cancers, but this is just another one to show you that it can be in bones. And we saw the osteosarcoma of the leg. Yes, we know that's there on the femur, but it can go into the scapula, the jaw. And I've given you some pictures of it to show you. And of course, we just want to make sure this doesn't metastasize. And can it be removed safely? I mean, it's a scapula. Can we remove a scapula? What would we put back in there? So, or is it a piece of it? Now, JIA is also known as juvenile rheumatoid arthritis. It is difficult to diagnose. I've shared this before. I have rheumatoid arthritis, and I sort of know what's going on, and it took almost 10 years to diagnose me properly. I had 5 different rheumatologists, and they are all telling me I'm fibromyalgia. And I'm like, I'm not a fibromyalgia. But finally, they found a test that they could test me with, and it's called a CCCP. And that CCCP high level is 50. When they got my level back with all the other stuff, ANA, rheumatoid factor, CRP, all of that stuff, instead of 50, I was greater than 250. So my rheumatologist said, well, I guess you're correct. I said, I've been telling you. Anyway, JIA, what we usually see, and we'll see it in young kids, ages 1 to 3. And what they usually come in with is they wake up in the morning and they're stiff and they hurt. And then they start that, you have to place your feet just so, because you hurt your knees, your ankles, your toes. So it's a difficulty walking. And especially if it's in your knees, you're going to be limping. And that's not normal for kids. Now, maybe you see joint swelling, maybe you do not. Usually that's longer term, but maybe an older kid, you'd see it. But then also uveitis. which has to do with if we don't treat it, it could go to blindness. So we need to do ophthalmology checks on that. So as I said, there's really nothing definitive how to test it. We do all of the inflammatory factors, the SED rate, the CRP. We do the anti-nuclear antibodies, rheumatoid factor, do a CBC, see if the white count's up. But sometimes you're flaring, sometimes you're not. So it depends on when you get the blood, doesn't it? So it's one of those really difficult things. Now, there's no cure. You got to treat it. And most of all, you're trying to keep your joints moving. I mean, you've heard me say many times, I swim every day. I swim as much as I can because that's the way my joints move and it doesn't hurt. Going out for a walk or a bike ride, I'm going to hurt a little bit, but that swimming is great for me. But whatever it has to do, I got to get up and I got to move because it keeps me my range of motion. NSAIDs are given for pain and they'll give you, usually put you on some methotrexate, whether it's subcutaneous or by mouth. There are oral methotrexate too, and put you on something like Humira or Enbrel or Symbia. I'm on an infusion now. I've been on 6 different types until they found one that's sort of working pretty good for me. So we'll stay there on that one. In flares, when you're hurting, they'll give you a dose of corticosteroid. But remember, there are just so many issues, corticosteroids with your blood sugars, with healing, with, your adrenals. They don't like to really give it that much. That they, as least as possible. So what do? Well, number one, you keep them moving, physical therapy, putting them in exercise, put them, to moving around and trying to keep them pain-free. Now, they say with JIA to put heat on it. Now, if you put heat on me when I hurt, it's gonna make me hurt more. I like cold, but it's either heat or cold, whatever it does to help alleviate the pain. And then moving it, trying to get the motion in there will help it, get out of the flare. Could last a day, a week, you don't know. It's just this knee hurts, and oh, that hip hurts, oh, that arm hurts, that elbow. It moves on many people. Some are one area that it tends to be the worst in. Again, trying to keep this kid as normal as possible. Now, lupus is the autoimmune where the body attacks all the organs, and it's usually girls. It is related and triggered hormonal, and we know menses and puberty, etc., can happen. It could be due to a lot of different things, but in South Florida, overexposure to sunlight could be one of the things that create lupus, believe it or not. I mean, you have to have the tendencies, etc., but it's one of the things. What do you see? Well, that butterfly rash, they call it cutaneous lesion. So it's affecting the skin organ, right? Your limbs. You can have nausea, vomiting, diarrhea. Now, usually by the time a child gets diagnosed, it gets to the point where they start getting forgetful, maybe have a seizure, or all of a sudden they have little paralysis. And that sometimes when they diagnose it, hopefully it doesn't get to the point of pleurisy and pericarditis. Because remember, lupus attacks organs. It's non-specific. Brain, lung, heart, doesn't matter. So if it attacks the kidneys, you'll see proteinuria. So lupus is treated in many different ways. There's many different sort of drugs. Usually steroids are given on these children, low dose steroids to help them. It helps minimize these exacerbations. And the other thing is keeping them out of the sun. Now, Kristen is 10 years of age, sustained a fracture of the epiphyseal plate of her right fibula when she fell out of a tree. When discussing this injury with the parents, the nurse should consider what? Well, what is an epiphyseal plate? Anybody? What do we worry about with an epiphyseal plate? You have a fracture there.
That
Is
it's
it
uneven.
Right. So bone growth can be affected. Yes. You see that. So epiphyseal plate, it's where it's the growth plate. If it's not positioned correctly, bone growth is going to be affected. Yes. Okay, chapter 49, neuromuscular, muscular dysfunction, it's cerebral palsy. Have you all met Jonathan in the downstairs room? My
Oh,
little
yes.
my
Yes.
little Jonathan, smile from ear to ear.
Oh
He
my
would look
goodness.
at me and he would he wanted me give him a big hug, and I'd always give him a big kiss, and I'm near and dear to him. He surprised me in many ways. What is cerebral palsy? It's a permanent disorder. It's all about the movement and the postures. They have no control of the way they sit, the way that they stand, if they can, and their movements. Why is it? What does it happen? Well, could be a hypoxic and anoxic episode at birth. That's where I've seen most of them, but it could be anything else. Could be something happened, brain bleed, etc. And the premature infants, these infants, their brain vessels in their head are so fragile, and they tend to burst and they cause interventricular hemorrhages. And it can go from level 1 to 4. And if it gets to a level 4, many of these children will have some form of cerebral palsy. So that's how it could. Now, when we have a kid with cerebral palsy, we're going to see delays, fine motor, gross motor, even speech. They're not going to be where they should be. And it's going to become pretty evident. That's why we learned all that stuff there. Now, spastic cerebral palsy, Jonathan, right? Hypertonicity, poor posture, and difficulty maintaining balance. He can't walk, and he's strapped into his wheelchair. He's, aphasic, he doesn't talk, and he does not eat by mouth. He has a G tube. So he's a pretty severe cerebral palsy child. So what do we see when we look? All of the above that I just said. Gross motor, fine motor, muscle tone, postures, even the reflex are going to be different. You know what surprised me with Jonathan? He has that little pad where he can talk to you. And I've seen him over in speech where they're teaching him numbers and colors and shapes, and he has a sense of humor. And he taught me that when I was a teenager, I worked for the Cerebral Palsy Foundation as a volunteer. I used to go there on Saturdays because these children fascinated me always. And we did not have speech, physical therapy, occupational therapy. We did just basic care. We fed them, we turned them, we changed them, and they sat and watched the TV. We didn't do much more than that. So to see Jonathan with a sense of humor taught me something really quick. The biggest thing with children that have this cognitive delays and they're unable to get around on their own, it's really important that they have a way. Number one, how do we get around? Jonathan has his wheelchair. How to communicate? He's got his pad. Now, he's not going to ever do things for himself. He's that severe, but there are very mild CPs that are out and they're professionals, and it doesn't hold them back. They might have some sort of leg that they wear a brace or something, but they're not what you expect. So, and they can function normally, go to college, etc. So with these children, we need them social. We want them around children, and once Jonathan meets all of what he's supposed to do, they'll make new goals for him and he'll continue to grow and to learn. For children that can get up, move around, foot braces, ankle braces, we don't want foot drops. We don't want it just to spasm down, right? I mean, some of these kids do have these walkers that they can walk around with, you know, that's through that physical therapy. Jonathan took Botox. He's also on carbidopa levodopa, which is for Parkinsonism, the shaky muscles. Let me tell you, he's better than he was, as in his spasms, and he's still quite spastic. And remember, these children, a lot of them have seizures. So remember those medicines and that hyperplasia of their, you know, their gums. We want to make sure that we keep those teeth clean so that we keep those teeth in. Prognosis depends. I mean, prognoses are better than they used to be. But remember, it's also those children. Remember the families, these kids go home. Do they have what they need? You know, especially a young, just diagnosed child with cerebral palsy. Do they know safety? Do they know about medication administration? How to get this child active? All about that they need speech and physical and occupational therapy, and where can they get it, etc. There's a lot of teaching that needs to be done here. And as nurses, it's just not you doing it. Remember, you do have social workers and other people that can help you take care of these kids. Now, neural tube deficits. Remember in pharmacy, they told you folic acid should be given 1 month before you get pregnant so you don't have neural tube deficits, right? Well, this is what that means. What happens is the lower extremities, they rips the nerves and the spinal cord, and the meninges cover it. That's the meningeal sac right there on the outside. And as I said, it pulls it up and it rips it up. So you're going to be seeing really poor sensation, movement of lower extremities. It can be due to many reasons. They don't know all of it. Obesity, diabetes, maybe low B12, genetics. They don't always know all of the answers there. But when we get one of these children into the newborn ICU on admission, you know, make sure we have saline and a good sterile dressing, because we want to prevent infection and keep it moist. Now, as I said, those nerves are pulled, they're stretched, they're broken, not the nerves that, you know, go down to the lower extremities. It also affects bowel control and it affects urine. Can they urinate by themselves? And many of these children end up getting every 4-hour catheterizations for life because they don't feel when they're getting big. And we want to make sure that we do catheterize them, because the urine will just go up and will get into the kidneys. And they don't feel it because they're numb down there, right? They have paralysis of the lower extremities. And these children at birth are made latex allergy. We don't use latex in Children's Hospital at all anymore, but we do put that there just in case. These kids are smart. So we should be taking folic acid, but we know you don't know all the time when you're going to get pregnant, do you? So here is a muscular dystrophy. We're going to do two. This is Wernig-Hoffman's. It's also the floppy infant. It is passed on to them. And this is one of the hardest things to watch. This child will never lift his head, will never turn over. They just lay there. They don't move. They're just very hypotonic. These children usually die before the age of 2. Their muscles just don't work. Now, Duchenne muscular dystrophy is the most tested muscular dystrophy on NCLEX and HESI. And Duchenne muscular dystrophy is given to the boy ages 3 to 7, and it comes from mommy. What you'll see is a kid, initially, they are a little delayed. They're not, you know, cognitively, they do have delays, but they do get up, usually are able to walk, and then all of a sudden, they start waddling, get weak, start falling down. you will notice that their calves are hypertrophic and their upper arms get really big, the muscles there. And it is a progressive muscle weakness and wasting. They usually die in adolescence because your diaphragm's a muscle and so is your heart, and it usually fails on them. So you get a kid who's 4 years old, mom says they've been falling down. How are we going to diagnose this? Well, we do something called an EMG. It's an electromyography. Sometimes they put needles, sometimes they just put those little skin tapes there. And what they do is they give that muscle an electrical current and they watch if the muscle responds to that current. It should spasm. Now, when they're done, it's like they ran a marathon because they're checking the muscles in the body. So they're going to hurt. It's like going to the gym for the first time in 3 years. How are you going to feel when you go home? You're going to hurt. Same thing. So let the parents know and let, tell her that when either before or after, give them something, ibuprofen, give them acetaminophen, give them something. Now, signs and symptoms that we see that would tell the doctor we're going to do that test. They're going to be waddling. They're falling down where they weren't that much before. And then Gower sign. That's like me when I get off the floor. I walk up my legs to stand up, okay? But a kid at 4 shouldn't be doing that. They just get up and go, right? Lordosis, their lower spine tends to curve inwards. And of course, those muscles, as I said, and the mild to moderate mental impairment. And these children, because they're not moving a lot, they tend to be heavier. We got to be careful we don't get them too heavy because, again, parents are going to have to put this child when they get to the point of a wheelchair or getting them out of bed. So we don't want them too heavy. So there's really not treatment. It's more of therapies to try to maintain function as long as they can, which is keeping them active, range of motion, physical therapy, occupational therapy. And these parents need to go in for genetic counseling. The mother, remember, X gene comes from mom. Now, Guillain-Barré. Guillain-Barré is when the nerves stop working. It's called an infectious polyneuritis. It's usually after some sort of infection, upper respiratory, viral. It's like 3-4 weeks earlier. And then all of a sudden, you see it in ages 4 to 10 in children. And what you'll see is a normal kid all of a sudden starts falling down, not walking the way they should. It starts from the feet, the nerves, and works up. Important, ascending, important concept. So as it gets up to the bladder, they might become incontinent or constipated. Those things could happen. Then your concern always with Guillain-Barré when you're considering it is remember the phrenic nerve pumps the diaphragm. And if the nerve doesn't tell it to, breathe, you're not going to breathe. So when it hits the phrenic nerve, they are not breathing by themselves. These children do need to be ventilated. And they usually, if we can get them off within 3 weeks, they do good. The quicker we can get them off is the best. So how do we treat them? Well, they're not breathing. They're ventilated. And remember their minds are awake and alert, but they can't move a thing. It must be so frustrating for that child. We treat it with IV, IG, plasmapheresis. We mean see if there's any toxins in the blood, maybe steroids, but IVIG is the mainstay. They're going to be monitoring their lungs always, O2 saturations, and then anything that we need to prevent complications. I mean, they might be on, stuff to prevent blood clots or things like that. But the big thing here is to monitor the respiratory. Now, they've gone from the feet up to the phrenic nerve. So they're paralyzed literally from the neck down. When all of a sudden this goes away, because it's acute, it will go away. The amount of time are all different, but all of a sudden, you're going to see the ventilator breathing more than what it said, which you know the child is taking breaths. And all of a sudden, they'll be taking more and more and more, and the child will now be breathing. And then all of a sudden, now they can feel they need to urinate, and now they're moving their legs and their toes, and it goes back to their feet. And if it's not been that long, there's not going to be that much stiffness and drop foot and all that stuff. They usually do pretty good. Now, tetanus, step on a rusty nail, right? Isn't that the old cliche when you talk tetanus? Tetanus, what is it? What does that mean? Well, it's above the shoulders. These muscles get so tense and so swollen, they occlude the airway, and it hurts. How do we get it? Well, you have a sore, you stepped on something dirty, it had tetanus in it, that rusty nail, or anything, be outside and get a wound. It should be cleaned, soap and water, and antibiotic ointment put on it. But if it's gotten in there, what are you going to see? Well, you're going to start to see this tense in the neck and the jaw. And then all of a sudden, the muscles in the face are spasming, and you can barely open your mouth. It gets to the point where your back is arching, and then you go into bronchospasm, and now you're going to be on a ventilator again. Okay. Treatment. We're going to give the tetanus vaccine for it. It's, they give these extra. Now, how often do we give we should be taking the tetanus shot? Do you know?
Is it every 10 years?
It is. It's every 10 years. But if there's something that happened, they could do two things with this. They can put it around the area that was wounded to try to get it at the entry, and then give you a booster. They will give you boosters at that point. And these children are sick. Because remember, now they're going to be on stream muscle relaxants so that they can help relax that muscle there. So they're going to be paralyzed sedated, which means they're going to be a little foggy in the brain, but they're still alert. Again, we're still going to treat, the wounds. We'll be giving those tetanus antitoxins, etc., to help them. And we'll just be monitoring their respiratory status. Now, whenever we have anyone paralyzed, sedated, fluid and electrolytes intake output are always important to watch. And as this child starts to relax, we can get them off within 3 days. Usually they're going to be okay. Now, many of you have had children and they get constipated, and Abuela says, oh, just give them a little bit of honey. That will help them go. Some of you have heard that, or Kara syrup. Well, it's not recommended at all. There's books I've read. One says up to after 1 year, and some say 2 years. So I just don't give honey, even to Christian now, who's almost 7. I just don't. And what happens is it enters into the body, and all of a sudden they start with vomiting, and then they start being weak and dizzy. In children, you're going to see respiratory issues. It's respiratory paralysis. Again, the treatment really mimics tetanus, whereas IV botulism, IVIGs, again, respiratory support, and always, always, always you worry about nutrition. Now, that little boy who came in with that C5, C6 fracture, He was a sports injury. I mean, there's a lot of different ways you can hurt your neck. Motor vehicle, you're hit, your neck goes forward and backwards, and it could snap something in there. Birth, you're pulling the head, getting them out, and injuries have occurred that way. So the biggest priority in any suspected injury of the spinal cord is proper immobilization. As I said, this child, he was 15, I believe, at the time. He has a great life today because I let nobody touch his neck and I kept it straight. And I also did an MRI in the ER, unheard of, but we needed to. So I orchestrated all of it, got it done. So that stabilization, they come off the copter, the trauma copter, yes, they're taped there, but making sure from there on they're okay. And trying to keep that poor boy, what was going on, what we're doing. It was a challenging day for me. So a progressive infantile spinal muscular dystrophy and the most common paralytic form of floppy infant. Do you remember the name of it? It's the wording Hoffman. Any questions? A lot of stuff. Are you with me, Christian? Where did you go? There you are. Okay. So who wants to win the Cahoots tonight? I know Kim likes to win them. I know Miguel likes to. Christian does. Kevington, it's your turn. All right. I like to smile. Here we go. And we're just about on the time frame I thought we'd be, so we're doing good. Thank you, Amanda. So do you all feel like you've learned something in pediatrics so far? Something you can use at your home, for your neighbors, just simple, just common sense stuff, and that's what nursing is. If you know the key word, you'll know how to take care of anything. All right, here we go. Week 9, I'm still amazement, 3 more weeks. We'll do a HESI review after the exam next week. We'll start it off. What is the priority for a nurse to assess following a CAST application? I mean, that's a pretty yellow cast. I wouldn't mind one like that. But I don't want one. I don't want to break anything. It's, the 6 Ps, pulses, pain, movement, sensation, all of those things you're going to be looking for. Not only you, remember, you're teaching the parents and the child about this. What should the nurse monitor after a soft tissue injury? Like a bruising. What are you worried about? So we don't know how deep that bruising is. We don't know if there's an occlusion of blood supply, and we don't want a child to lose a finger or a toe. Neurovascular checks, absolutely. Pulses, capillary refill for sure. A fracture that penetrates the skin is called Simple is the normal crack, skin is fine, put a cast on. Compound is when the skin is open and you can see the bone. What is the priority nursing care of a child with that compound fracture? You have a child has a big, laceration, the bones coming out. Your number one concern is infection. So IV antibiotics, that is your big thing, okay? Priority nursing care. And of course, you're going to do checks, but you want to prevent infection. What is a priority nursing care for a child who fell off a second floor balcony? And I have seen this. I've seen more than one child, different ages, get up on a table and lean over and fall off second stories, balconies. And that's always, they fall off. You're always concerned about a spine injury. So strict immobilization. You're going to see rescue. They're going to put a collar on and tape these children right to the backboard to bring them into the ER. Principles of managing soft tissue injury include what? You get a sprain, you get a strain. What are you going to do? And that's rice. Rest, ice, compress, and elevate. Think of me on that volleyball court. My foot went straight up, and it did help a little bit. Epiphyseal plate fractures in children may what? What is an epiphyseal plate? Remember, it's the growth plate. We are worried about the growth of the bone. It could be disformed or it could be shorter than the other leg, arm, finger, toe, whatever. You got to worry about them. What findings for a patient in skeletal traction indicate peripheral neurovascular impairment? So if there's neurovascular impairment, there's no pulse. We're going to have prolonged capillary refills. The color's going to look pale, all the above. Those are your neurovascular checks. Multi. How should the nurse care for the skeletal traction for a child with a fractured femur? And it's skeletal / skin. Years ago, we never did skin. But today, before we used to put Steinman pins in and keep them in the hospital for a month. Today we put them on skin. We get them into the OR and they put a metal rod down the middle of the femur to hold it. So the recovery is a lot less and less time in the hospital. Big thing is that there's weights hanging. They must hang and swing freely. That pulls the bone. When you remove it, those bones will go back and create a lot of pain. And you want to maintain, the proximity the way it should. So document the weight and keep those weights hanging so you're pulling at all times. When caring for a 9-year-old in Buck's traction, what action by the nurse is correct? So the big thing is to check capillary refill, check your neurovascular signs. We are not putting the weights anywhere. We're not going to have anybody touching, raising, and lower the bed. And you're not going to have people sitting on the bed jostling it because that creates pain for the child in the bed. A multi. Which assessment indicates an infant has developmental dysplasia of the hip? So a moral reflex is the startle reflex of an infant, okay? Babinski is when you hit the bottom of the foot, just like adults. It is those leg folds, those gluteal folds, they're irregular. And then the positive Ortolani sign. Are you hearing that clicking as you're moving it around, okay? And a shorter leg. What position do you put the legs of an infant with hip dysplasia? What do you do with it? In this position, hopefully we'll get that socket back into the hip joint. And it's called abduction. Remember that one. It's not ad, it's an ab. What statement by parents indicate more teaching regarding their 2-month-old with club feet or 2-week-old? And those feet, that's a really severe club foot. They're really inward and they're twisted. How do we treat it? Think about to then. What did I say? Well, we're going to put them in as soon as possible. What's more teaching? So this means which one is wrong, okay? Treatment starts soon as possible. They're going to have follow-ups as they get older, and it must be changed every week. Waiting for 1 month, remember how quick newborn, that first 28 days, they heal in 2 to 3 weeks. You wait for a month, and now you've got a child with crooked feet, and that's going to be harder to get them back where they need to be functional. A multi. Osteogenesis imperfecta. So it's brittle bone and they're crooked. It's all about multiple breaks. Now, I want you to know that many infants born with this that go undiagnosed are charged with child abuse because of the amount of fractures. And then they have to prove, no, I didn't do it. And I've seen documentaries on that. Now, you're not going to do aggressive physical therapy. Remember, I told you I don't even want to touch these kids because you can break their bones easily. So you're not doing aggressive anything to this child. What is the pathologic cause of leg calf burst disease? So remember, it's aseptic, no infection, and there's some sort of ischemia. The blood supply, for whatever reason, stops. So it causes necrosis of the femoral head. Yes. What is kyphosis? Kyphosis is the upper back. That is that humpback. And what is lordosis? So lordosis is that inward of the lumbar spine, and we see that in Duchenne muscular dystrophy. And what is scoliosis? Remember I said to look at it, scoliosis S, and that's your clue. And it's that S-shaped curvature of the spine. Remember, we worry about really big curvatures, greater than 40, 50%, because those will impede on the lungs. So adolescents with scoliosis that have up to a 45% curvature of the spine would need to. So you're up to 45%. What are we going to do? How are you treating that S-shaped curvature? And this is the one where you wear a brace. Surgery is over 50, 55. That's when you do the surgery. Up to 45 means it's below. It's that brace 23 hours a day and physical therapy strengthening the muscles. What is osteomyelitis? It's an infection of the bone, period. Inflammation is an infection of the bone. So goals for juvenile idiopathic arthritis include so what is JIA? JIA is when it's an autoimmune where the body attacks the joints. And our goal is to keep that pain and swelling to a minimum and keep that functioning, right? But the goal is to reduce the pain and swelling so we can be normal children. A multi. What might you anticipate for a child diagnosed with JIA? What are you going to see? Everything but the facial rash. And the facial rash is what? Lupus. Joint disfigurement, difficulty walking, and then, as I said, the eyes could lead to blindness if we're not careful. A multi. What can help a child with lupus erythematosus prevent exacerbations or flares, if you want to call it that way? So you're going to wear sunscreen, you're going to decrease that exposure to the sunlight, and then always prophylactic. Really has nothing to do with diet lupus at all. What organs can lupus affect? I ask some of these questions to make sure you fully understand what does it mean. anything. Skin is an organ. Any organ, anything, lupus can affect. What is cerebral palsy? My poor little Jonathan. You still going Tuesdays to clinicals?
We are through
Wednesday.
today, Professor.
You're all
Today was
done?
our last day.
Today.
No, we go tomorrow for our last one.
Okay. So cerebral palsy affects body movement and coordination, right? They can't move the way that they want to. It's just really difficult. A myelomeningocele. What is that? I mean, some people call it spina bifida, right? It's when the spinal cord and meninges are pulled and ripped out and it's pulled to the top of the skin. It's one of those closures again. We've talked gastroschisis, bladder extrophy, and now it's myelomeningocele. Something from inside is born on the outside. Our goal is to keep the moisture and infection free when we have a myelomeningocele. We don't want the spinal anything to get an infection. Infants with myelomeningocele demonstrate what? You know, many children with this are absolutely normal kids. They are just going to be in wheelchairs and because they can't move their lower extremities. Motor sensory impairments is what you're going to see, but many times their brains are perfect. Myelomeningoceles have decreased motor and sensations of lower extremities. The nurse should monitor closely what? What is your priority to be monitoring these children? Remember, those nerves are ripped out of the lower extremities and there's numbness and they don't move. You know, they don't feel down there. So what's the big deal? It's urinary retention and bowel function. Okay, those two things. Foot drop, skin breakdown is not as important as urinary retention. We want to make sure that we drain that bladder. A key feature of Duchenne muscular dystrophy is what? What is that? Muscular dystrophy. What does the words mean? And it's that progressive muscle wasting. All of a sudden they start falling and waddling and, you know, they go to the physician and then they're going to check them with an EMG. What is the procedure that a child with possible Duchenne's may need to diagnose this condition? And it is that EMG. Again, remember, it is sending muscle electric into the muscles, looking for it to contract. It's like they run a marathon when they're done. They're going to hurt when they come back from that. So make sure you give them something. How is Duchenne muscular dystrophy inherited? How do you get it? It's from mom. X-linked recessive. It's from mommy. And mommy always feels guilty, like they want to have another kid. And you're going to say, well, chances are if it's a boy, it's going to have Duchenne's. In caring for a patient with Guillain-Barré, the priority concern is what? As a nurse, what are you most concerned about here? Remember, it's the nerves stop working from the feet going up. What's your biggest concern? It's that airway, because that phrenic nerve is going to stop working. For a patient suffering with Guillain-Barré, they would complain of weakness. That was what? So it's what we call ascending. It starts from the feet. The numbness starts with the falling, weakness, shuffling, works up, starts incontinence, constipation, or, incontinence, and then it goes up and it hits the lungs. When you're done and you start to get better, it goes down and you start to feel your urine again. You start to feel your feet again, and then it's gone. So it goes up, ascending, and then when you get better, it goes descending. A multi. Treatment for Guillain-Barré include what? So it's a viral thing, so antibiotics are going to do nothing. The treatment for Guillain-Barré is IVIG, maybe steroids, and respiratory support. Heparin is given just as a prevention of clots, etc. But treatment, Guillain-Barré, IVIG, and respiratory. What type of cerebral palsy causes hypertonicity and poor fine motor skills? And this is Jonathan. And it's called spastic. That's the word. He's just so spastic, okay? What priority action should a nurse take to a patient with a suspected spinal cord injury? What's your priority? You think something's going on with that spinal cord. You see paralysis, no movement, something. What are you going to be making sure you do? It's that immobilization of the spine. Always remember the story I tell you, because I, to this day, am happy that, yeah, I was a pain to many of the people dealing with moving this child, but this child came out and had full recovery because I was like that. It's a nurse's job to do that. So you should get a tetanus shot every how many years? They're giving it with diphtheria now as a booster with it. Used to be plain, but now no. And it's 10 years. Good. What is a symptom of tetanus? Got a dirty nail, rusty nail, you stepped on it, you got a puncture wound. What is that big thing that happens? And it is extremely, this child is so sick. And it's all about that swelling and compressing the airway, that lockjaw, that muscle rigidity, stiffness. And last question. Most common causes of spinal cord injuries are what? accidents with motor vehicles, always, driving or in sports. Those are the big things you see. So let's see how we did today. Number 3, Leslie. Good job, Leslie. You made it through. Ari, number 2. Good job. Number 1. Who's the shy one? And Miguel and Jordan. Good job, guys.
Too many
So
smart people in this class.
You a lot of smart people. You absolutely are. You're Cutler Bay. You're my old alma mater. You know that. So remember, next week is an exam. Exam reviews are going on like crazy right now. So I've already posted my review. I did it today. I'm about to post another one from Professor Peshizmar. She's actually pretty good. So I would listen to her if I were you. So try to be a little bit early next week so that we can get you up and done. And when we're done, I'm going to start our HESI reviews. I've got some good stuff for you to help you through it. So I'll be handing you 2 Huggies type of the Cahoots, 2 of them. And I also going to do on Sunday before week 11 of week 11, I'm going to do a Q&A, as I call it. And I'm going to go over concepts, topics that have been on the past HESIs, and I'm going to explain how to think, how to work through the question so that you can answer them, okay? So I wish you good luck. I'll see you next week. Study hard.
Good night.